This video describes the development of the blood supply to bone and reviews clinical examples demonstrating the related physiologic implications. This video series on osteogenesis recapitulates original work by Lent Johnson and Donald Sweet, including photomicrographs from the Armed Forces Institute of Pathology collection. This series summarizes these concepts as prepared and presented by Dr. Sweet to Canadian residents in a monograph and brilliant lecture for 17 years prior to his passing. We posthumously honor both consummate educators whose model for teaching orthopedic pathology has been replicated in part in the COA Basic Science course. Cartilage is inherently avascular. With the development of the primary center of ossification, vascular ingrowth occurs initially as capillaries, and then expanding into a sinusoidal vascular network that becomes the primary internal supply of blood to the bone. The cartilage cell cycle is a sequence of rest, proliferation, hypertrophy, leading to terminal differentiation and death. In the center of every cartilage model bone, under the influence of multiple osteogenic markers, a primary center of ossification, or PCO, develops. The circulation develops as the PCO forms. Vascular ingrowth occurs initially as capillaries, then expanding into a sinusoidal vascular network that expands to the ends of the metaphysis and becomes the primary internal supply of blood to the bone. A sinusoidal vascular bed is a network of terminal blood channels consisting of large, irregular anastomosing vessels having a lining of reticular endothelium but little or no adventitia. This system traverses the nutrient foramen, a canal in the middle of bone giving passage to the vessels serving the medullary cavity. So how does this all happen? Circled is the PCO of an embryonic long bone. Its formation is an incredibly complex symphony of multifactorial, linked, sequential, geographic events, such that the contour of the bone does not change as it grows. The process begins with a collar of woven bone applied at the margins as the cartilage calcifies and the cells die. The cartilage varies in staining, light blue in the ends and darker blue, the calcified cartilage in the entire middle. The cells, buried in matrix, vary in size, each going through its life cycle in place, including 1. Rest, 2. Proliferation, 3. Hypertrophy, and 4. Senescence and apoptotic death. In the symmetric ends, the cells are small and resting, then sequentially progress through each step, thus showing the regional pattern of growth plate morphology. There is as yet no vascular invasion, but the calcified cartilage in the middle, and the adjacent cells are senescent or already dead. Vascular invasion is about to occur. The region is hypoxic. The cells are dead or dying. An array of markers, mostly unknown, is at play. The relevant steps in forming the PCO are strongly influenced by the marker vascular endothelial growth factor, VEGF. Vascular invasion, endothelial cell proliferation, internally creates nutrient vessels and externally the periosteal vessels. Bone and cartilage deletion, performed by osteoclasts and chondroclasts respectively, creates space for the nutrient foramen and the primary trabeculi. And bone formation creates structure, the woven bone cortex and the endchondral trabecular array. In forming the PCO, vessel and bone formation have a hand-in-glove relationship, varying geographically in terms of timing and control. Each process is associated with an array of osteogenic and vascular markers. VEGF controls vascular invasion in the PCO. In the perichondrium, it is produced by cells which, through RUNX2, enter the bone formation pathway, leading to forming the bone collar. The perichondrium becomes the periosteum, initiating the process of bone formation underneath. At the level of hypertrophic chondrocytes, VEGF is produced by such cells in the diaphysis, and this later is the site of the vessels of the primary spongiosa. Slide A is the PCO just before vascular invasion. Slide B captures the moment when a clast is deleting calcified cartilage. Others have already deleted large areas, leaving ragged holes in the structure. The nutrient foramen has been opened by osteoclasts, creating a window in the collar. Clasts have rapidly formed and have burrowed through a large swath of calcified cartilage, creating space. This will be invaded by proliferating endothelial cells, creating a sinusoidal vascular bed in the medullary space. Accompanying are endothelial cells, mesenchymal stem cells, pericytes, and monocytes. All cartilage cells are dead or in terminal apoptosis. Cellular detail is not well seen, but some of the larger cells are likely chondroclasts. B is a cross-section through the center of the PCO, a few days to a week after the time of the specimen in A. Let's sequentially identify its parts. In B, then, from the left to the right, you can identify skeletal muscle M, multi-layered periosteum P, and cortex C. In the medullary space, there is a network of irregular blue-staining calcified cartilage. Endchondral bone formation is just beginning, as small areas of cartilage have juxtaposed red material that is globular bone. These are primary trabeculi. The adjacent open spaces have reddish material, likely red blood cells, in the forming sinusoidal vascular bed. Slide A was 1 week after osteoclast invasion and endothelial cell proliferation initiating the nutrient vessel system. Slide B is yet another week later. More striking is the continued development of the vascularization of the medullary space. There are now clearly organized sinusoidal spaces containing masses of red blood cells. Flow is turgid, and the PO2 is low, the ideal environment for bone formation. There are now only a few primary trabeculi. Massive clastic activity has been necessary to delete most of the trabeculi, leaving a mechanically necessary chosen few that will remain until continued growth and stabilization makes them unnecessary. Now let's focus on the development of the circulation in these two digital specimens, fetal in A and in a newborn in B. In A, the medullary space of the diaphysis has been substantially cleared of primary trabeculi through clastic activity, leaving a space containing a fibrovascular stroma supporting the initial endchondral bone formation, first globular and then woven bone applied to the calcified cartilage template. As remodeling by clasts eliminates the trabecular bone, a sparse network of sinusoidal vessels proliferates to fill the space that extends to each metaphyseal growth plate, there to form the capillary bed that supports the primary spongiosa. The cortex, emanating from the periosteum, derives its circulation from the periosteum and the adjacent musculature. The cartilage on either end remains avascular. B is a longitudinal section through the middle of a child's finger at birth, with skin, subcutaneous tissue, cartilage end caps, marrow space, and cortex. In A, there is a radiographic correlate. Cartilaginous ends of the bone are not yet visible. The cortices are lamellar bone, reinforced woven bone, termed fibrolamellar bone. In B, you see growth plates on either end, joint spaces proximally and distally, with well-defined synovial recesses. An early tendon sheath is also present. This even before the joints are fully developed. The marrow space, now filled with hemopoietic cells, has a life cycle all of its own. It starts out as a fibrovascular reactive tissue involved with the formation of the primary center of ossification, and this then becomes the central sinusoidal vascular network. This task done, it then becomes populated by deeply basophilic staining hematopoietic tissue. As growth occurs into adulthood, the hematopoietic tissue involutes and is replaced by fat in all but the axial skeleton. The vascular supporting network remains with a sparse perivascular array of stem cells. It is this network that is called into play when imbalance or disease presents throughout life. The radiograph shows the tibia in a skeletally immature individual. The nutrient vessel system originates from the capillaries that penetrated the cartilage model, becoming the perforating arteries. These supply the medullary space up to the epiphysis on either end, ending as a sinusoidal vascular bed, and the inner third of the cortex, as well as the endosteal trabecular bone on either end. The periosteal vessel system arises from vessels supplying the periosteum and adjacent muscles, providing circulation to the outer third of the cortex. The epiphyseal vessels arise from a number of vessels perforating the capsule, which ramify to provide flow to the epiphysis and the adjacent half of the metaphysis. There are innumerable anastomoses between each of these networks, allowing for divergence of flow to pick up areas of altered blood flow, for example, endosteal reaming. There is a separate and distinct vascular bed around the metaphysis and epiphysis. A number of vessels perforate the capsule and ramify to provide flow to the epiphysis and the adjacent half of the metaphysis. Circulation to the growth plate arises from three sources. The epiphyseal artery ramifies in rake-like fashion through the reserve layer to the top of the proliferating layer, supplying the first 4 to 10 cell columns. The nutrient artery terminal vessel loops supply the central 4/5 of the metaphyseal side of the plate, ending at the level of the last intact transverse septa of the calcified cartilage. The metaphyseal arteries supply the remaining outer 1/5. Clinical examples allow perspective on these concepts. This is a Civil War Macerate specimen and corresponding radiograph. There was an amputation for chronic infection. There was a draining sinus, termed a cloaca. The radiograph shows a bone within a bone, and the ends of the bone are normal. The pathologic sequence is that pathogens were introduced by the bullet. An acute inflammatory response raised interosseous pressure, leading to necrosis of the marrow space and inner cortex. The rising pressure forced pus through the cortical capillary system to the periosteum, physically separating the cortex from it, severing the external blood supply, inducing necrosis. The cortex now becomes a sequestrum, radiographically denser than the surrounding viable involucrum. And the following two cases show juxta-articular osteoporosis, reflecting the shared blood supply on both sides of a joint. The radiograph shows at the PIP that there is juxta-articular osteopenia and joint space narrowing. There's erosion of bone adjacent to the articular surface, and the pathology demonstrated acute suppurative bacterial infection. There is remarkably increased blood flow to the region in the presence of acute infection. High flow states and cytokines from activated T cells are associated with increased osteoclastic activity. In this case, chronic TB has induced autofusion of the joint, with accompanying regional osteopenia and dense sclerosis of the ilium, felt to be partially mechanical. Dr. Johnson had noted the presence of osteoclasts in these high-flow, high PO2 states and coined the term active hyperemia. Cell biologists are now trying to determine the relationship between the immune system and bone metabolism, especially the osteoclasts. Activated T cells liberated from marrow niches are associated with these states. When the growth plate is open, there are 4 sources of blood to a pediatric long bone. First, the nutrient vessel system enters by one or more oblique apertures and supplies the contents of the medullary space, the inner third of the cortex, and includes the metaphyseal trabeculi. The periosteal vessels supply the outer third of the cortex. Completely interlinked anastomoses between the inner and outer systems ensure that the middle third is supplied according to local need. There is a separate and distinct vascular bed around the metaphysis and epiphysis. A number of vessels perforate the capsule and ramify to provide flow to the epiphysis and the adjacent half of the metaphysis. Joints, therefore, are protected entities, and interruption of the nutrient or periosteal systems does not affect adjacent joint circulation. The adult long bone has identical nutrient and periosteal systems. After growth plate closure, the epiphyseal system merges with the metaphyseal, leaving a single metaphyseal system. Cortical circulation includes the inner one-third from the nutrient artery system, the outer one-third from periosteal vessels, and an intracortical network and an anastomosing array of Haversian microvessels, which are longitudinally oriented, and Volkmann's vessels, which provide transverse anastomoses. Epiphyseal and metaphyseal networks arise from neighboring or capsular vessels and include multiple vessels with shared circulation on either side of each joint. The epiphyseal and metaphyseal networks are separate systems in children, and they unite as one with growth plate closure, initiating a massive remodeling process thereafter. And finally, the intermedullary veins coalesce to a thin-walled central sinus. That terminates this video.